So good afternoon, everybody. Can you see the screen? Okay, yeah. So somebody's replied. Okay. So how are you all? We'll start our class today. Okay. So our topic is how many of you are here? I can see 59 students are here. So shall we start? What do you suggest? Okay, maybe we can wait 2-3 more minutes and then we'll start the class. So I'll just brief you about the class. So today's topic is about behavioral disorders. So behavior, as you know, is these behavioral disorders, they are different in different age groups. So in children, different age groups have different behavioral disorders. Common ones, are like temper tantrums and breath holding spells. These are the common ones which all of you would have noticed when you have kids around you in the house. So it's an important topic because also for your exam and plus even for your day-to-day lives, because many times there are children in the house which have these behavioral issues and then you don't know which is normal and which is abnormal. So it's very important to know where do we characterize these things as normal and when do we say that these are abnormal. So, okay. So today's topic, as we know, is behavioral disorders. The next topic, which is on autism, the types of behavioral disorders, autism and other behavioral disorders will be attention deficit disorders will be taken up later on. So we'll start with our session. Yeah. So So we should know whether it's physiological or pathological. Like I talked about, that we need to know whether it's a physiological thing or a pathological thing. So we need to know the age of the disease at which the disorder we are noticing. We need to know what is the development level of the child, whether the child has developmental delay or the child is developmentally normal or abnormal, that is he has a delay. The frequency of behavior, that is how frequently does the child have that sort of behavior, which is a repetitive behavior, occurs at say 5 days, 7 days, or 4-5 times in a day. So we need to know what is the frequency of the behavior. Other thing is intensity. What is the severity of the behavior? So is it very severe, life-threatening sort of situation? And what is the setting? So setting is very important because breath holding spells, when they occur, we need to differentiate it from a normal seizure. So setting is what situation does the child have that behavioral disorder? So we need to know in what setting does the child have that behavioral disorder. Whether he is upset, then he has it. Whether he is, angry at the peak of his anger, then he is having it. So all that is important, that what is the setting at which the child is having the disorder. Okay. Yeah. 1 second. Sorry. Yeah. So in general, this is how we define behavioral disorders: behaviors that occur at high frequency, at high intensity, and in the presence of multiple caretakers in multiple environments is suggestive of a behavioral disorder. And very important here, that's why I've written in bold, is that your organic cause has to be ruled out. If the child has a seizure, has an intracranial lesion, then you will not call he has a breath holding spell, right? So very important here is this point, which is very important, that you have to rule out an underlying organic disorder, right? Okay. So this is how we define behavioral disorders. Okay. So the common behavioral disorders are your infant crying, which is colic, which usually occurs in the infancy in the evening time, that is the infantile colic. Breath holding spell, you all have heard of it. When children hold their breath, turn blue, that is breath holding spell. Disorders of elimination, this is enuresis, encoparesis. Then temper tantrums, that is when the child throws a tantrum, he lies on the ground. Then disorders of feeding, then thumb sucking, head banging, nail biting. So these are very common disorders which you keep seeing in your day-to-day life, in your surroundings, in your society, and you should be aware of which is abnormal and how to deal with these disorders. Okay. So infantile crying, there is a way to define it. Not every crying is an infantile crying or a colic. So it is crying for more than 3 hours a day, for more than 3 days a week, for 3 weeks. So this is how they define. This is grossly the definition of infantile crying. It's not that as if a child will cry 2.5 hours, so we will not call it colic. So, you have to take it in the broader sense. This is for your clinical guidance that if the child is crying such long hours several times a week for prolonged weeks, then it is probably a colic. So you're dealing with a colic. So very important here again, that's why I've written it in bold, is the child has to be healthy. So it's not a crying child when the other things are wrong with the child. That is either the child has an infection or the child has a meningitis, and you think that the child is crying, so it's just a colic. So very important is that the child has to be healthy and feeding baby. It's not a cranky, ill baby. It's not a sick baby. So it has to be a well baby. And then when he has these crying episodes, that is when we call it colic. Okay. So, and again, most important is you have to rule out all the organic disorders. You rule it out on history and examination. You look for infections, take history of fever, take history of, any loose motions, any trauma, any eye problem, or, examine the child, look at the ears, look at the meningeal signs, look at the anterior fontanelle. So if any of those are one of the causes, then it is not infantile colic, and probably there is an organic cause. So when all the organic causes have been ruled out on the history and examination, that is probably, and when you have a healthy and a well-feeding baby, that is when you're probably dealing with a colic, right? So underlying conditions, there can be cow milk allergy, lactose intolerance, constipation, gastroesophageal reflux, or temperamental issues. These are the common things which are underlying when the child has a colic, infantile colic. Okay. So management consists of a thorough history and physical examination. We already mentioned that. Investigations, if you think that the child has an infection, you can do investigations like that to rule out underlying conditions. And treatment is basically parental education, counseling, and soothing agents, these simethicone oil and fennel oil. However, most of it, I would say, is counseling. So you counsel the parent well, that most of it is, a behavioral thing. It will go with age. So that is what is most important. Okay. So the next most important disorder is breath holding spell. So most of you would have heard or witnessed a spell, in the society or in your neighborhood. So one thing, is there a question? Let me see. Is there a question? I can't figure out. One second. How do soothing agents help? Somebody has asked. So actually the origin of these, somebody's asked this question, that how do soothing agents help? So we'll come back to this. So most of it is actually these disorders, they deal, so the problem here is that the child is having a colic because, this is a way of his normal gastrocolic reflex. Okay. So soothing agent will help in relieving that gastrocolic reflex and will help in reducing the, you can say, the pain sensation or the discomfort he's being caused, because they say there is contributing GER, there is contributing lack of probiotic bacteria in the gut. So, soothing agent is just a way of soothing the child, and it helps in reducing the discomfort which is caused to the child. But mostly these things are physiological, and with time, what mostly we advise to our patients is that you let the child lie down on his abdomen, make the child prone, give him a good massage on his back, and most of this gas and GER that will improve. So does that answer your question? Okay. Yeah. So next we go on to breath holding spells. Okay. So we were talking about how breath holding spells are so common, and most of us have witnessed this in and around everywhere. So the age is very important again. Like we said, infantile colic occurs in the first 3 months to 6 months. This occurs between 3 months to 18 months. So if it's a child between 3 months to 18 months, then we can call it a breath holding spell. But if it's a younger child, say a newborn, or an older child, say a 4 or 5 year old child, first time having something like a breath holding episode, then probably it is not a breath holding spell and it is something else, you should view it with a pinch of salt, that a child having an apneic episode at 1 month of age, it is very less likely to be a breath holding spell. Most likely what it is going to be is at that age is going to be a seizure. So the age is again very important. We talked in the beginning about the age of onset. So 3 months to 18 months, but usually after 6 months they start. Males are affected more than females, and it is actually involuntary, and it usually occurs during expiration. So mostly they are cyanotic or pallid or mixed. This is classified on the basis of color. So what happens in the breath holding spell? So what happens is that you will have a child who will suddenly start crying, and he will be upset, say he doesn't get something of his choice, and then he gets upset, he will start, or he gets startled, say he gets hurt, he falls down, he gets upset that he's hurt, or somebody's hit him, or he himself hit him, or you don't give him an object he likes. So he's going to be upset, he gets startled, and then he begins to cry. So what happens is, when he begins to cry at the peak of inspiration, what happens is that the child becomes silent. So there is usually a trigger, that is the child becomes upset or startled, then the child begins to cry, so there is crying, and after that the child becomes silent. So there is a sequence of event which takes place, which would not be the case in other things like seizures or something like that. So you need to differentiate. So simple breath holding cells is when this cycle is followed and the child becomes cyanosed. So usually the simple one lasts for a few seconds, and then it turns to normal. And a severe one, there can be even loss of consciousness, or there can be limpness, reduced muscle tone, and occasionally there can be hypoxic seizure later on, not initially. Okay, so we need to differentiate it. Yeah. So this is the pathophysiology which is behind. So grossly what you should know is, actually it's a dysregulation of your vagal response, right? So when there is exaggerated vagal response or dysregulated vagal response, what occurs is this breath holding spell. Another important mechanism is association of iron. Okay, so there is association of iron, so that is why in the treatment we give iron therapy. Okay, so again, here I'd like to emphasize to differentiate it from life-threatening other disorders like seizures, like your arrhythmias. So, where mostly in all these disorders, what is the key to all of this is the history. So, you take the history, the child had a trigger, then he got upset or he got startled, and then he started crying, and then he became silent, and then he threw a spell. So that is called a breath holding spell. Or so you need to differentiate it from the seizures which occur without any provoking agent in a sick child. Okay, and this breath holding spell would be in a healthy, happy, active, alert child, right? And also you need to differentiate it from cardiac disorders. So cardiac disorders child, by history you can make out that there are history of, say, repeated episodes of pneumonia, always the child is blue, and in these spells the child becomes increasingly blue. So that is how you differentiate. So most important is this point number 1, you take a good history, do a good examination, differentiate it from all the life-threatening disorders. And then if you don't find anyone, then it is probably a breath holding spell, and you have that characteristic history that we mentioned, right? So if you don't find the characteristic history and you think there's an underlying disorder, you can do a hemogram, you can do ECG or EEG if you think it's a seizure or a cardiac event, right? So if you think that it's not any of those and it's just a breath holding spell, all that you do is you reassure the parents, reassure them that this is just a breath holding spell. It is not a cyanotic spell or a seizure. It does not have anything to do with the brain of the child or the heart. So the cardiac and the CNS evaluation is normal. The child is normal. You reassure the child, because this is mainly because of your either underlying iron deficiency, or overall the child is just a bit pampered. So reassure the child that the parents that nothing has to be done, right? And give iron supplementation. So it has been seen in various studies that iron supplementation helps a lot in the therapy of breath holding spells. And rarely when there's a lot of vagal activation, you can give atropine, right? Okay. So next important disorder is your enuresis. So it is repeated voiding of the urine, right? And it is involuntary or intentional after the development age when bladder control is established. So very important is again the age group at which it occurs, right? It is not just at any age group it occurs and you are going to call it your enuresis. So it is after 5 years of age that you call it enuresis, right? Okay. And so it is 2 times a week in a child older than 5 years of age for 3 consecutive months. Okay. And it is causing significant distress to the family, okay, or impairment in social being of the child. So it can be nocturnal, that is quite relevant from the name. It occurs only during night or during sleep. This is more common. That mostly children are dry in the day and they have problem only at night, right? This is more common, nocturnal enuresis. And diurnal is that it is also in the day and it is obviously at night also, right? Yeah. So this also further we characterize it as primary or secondary. So primary, as the name suggests, it is if the child has never attained your dryness, that is the child has never been continent. Okay, so here also very important is the age group. We cannot say for a 2-year-old that it is enuresis. We don't expect the child of a 2-year-old age to be continent of his bladder. So it is above 5 years of age who has never been dry at night and now he is having enuresis, right? And secondary is when he has previously been continent, right? Previously that for at least 6 months. It's not 1 or 2 months, at least 6 months. So as for 6 months, the child was well, the child was having continence, and now he's having urinary incontinence. That is your enuresis. So that is primary and secondary, right? So primary is usually multiple factorial. That is the ones which are usually that there is immaturity of the nervous system. Some children have detrusor activity, or they overactivity, or they have a psychological stress, or they have a spina bifida. Okay. And secondary is usually there is a organic cause. Usually it is pathological. So UTI, constipation, spina bifida, occulta, or spinal any spinal tumor or anything, or psychological stress. So here I'd like to specify that constipation is one of the most common underlying cause in patients who come with enuresis, because this constipation leads to a full rectum, and actually that rectum presses on the bladder. So ultimately there can be UTI, or otherwise also there can be enuresis because of the full rectum and the anal canal which is pressing on the bladder and the urethra. Okay. And another important here is psychological stress. So especially when we did define about the age, so it occurs in children about 5-6 years of age, and maybe they have been previously continent or incontinent. So mostly psychological stress occurs, especially when the child feels that sometimes there is a younger sibling's birth, or the child feels that the younger sibling is getting more importance. So that is, or there is a family dispute in between the parents, or there is a family dispute, family abuse, some sort of family problem is there. So that is something like that could be a manifestation of the child's psychological stress, which actually comes out as enuresis. So whenever a child with enuresis comes to you, you have to keep all that in mind, and then take history of all those pertinent points. That was he continent before? What is the age of the child? Is there any psychological problem in the child? Is there history of constipation? Is there history of burning micturition? Okay. Is there any spinal problem? So you do a full history, like we said, of the age of onset, the problems in the family, any UTI, any constipation, and do a full general physical examination to look for any spinal problem or any other organic problem. So that would help you to know that what is the cause of your enuresis. So that's what they have mentioned here about the developmental history, rule out a renal disorder, constipation, most important, diabetes, psychological stress, try to find out about the family history, the family tree. What is there any problem between the parents, between the family? Is that the child feels stressed because of the younger sibling or the oldest sibling? So, or there is some physical abuse in the family. So that sort of history all is important, because many times that may be the only cause you find out. You try finding out spinal causes, constipation, and you find none. And actually there's a psychological trigger in the child, that he is feeling neglected, or he is being scolded at home, or any sort of family problem. So psychological history is very important, family history. So look for neurocutaneous markers, spina bifida, we discussed about that. And yeah, also important is when you palpate for the abdomen, as we said, constipation is very common. So look for fecolates. So you feel fecolates like small lumps in the abdomen, and usually on the left side in the iliac fossa, you can find these small pellet-like lumps. And also look for a full bladder. Look at the genitals. Look at the perineal area. Any tears or fissures. And you can even do a per rectal examination to see a full rectum. Okay. So if you think that there's a UTI, you can do a urine analysis, an ultrasound KUB, urography, MRI spine. If you see a tuft of hair, or there is some developmental delay, some problem in the tone of the lower limbs, then you can think of an MRI spine, but definitely not in all patients. So you need to do these investigations, but first you take a history and a good examination, and then when you decide, then will you go on to your tests, right? Okay. So coming to the treatment, which again, first line is behavior therapy, psychotherapy, or counseling, whatever you may call it. So you counsel the parents that for urination, you don't have to scold the child. So always positive reinforcement is better, as we know that positive reinforcement is much better than your negative reinforcement. So don't try to scold the child. Try to reward him when he is, passing urine at the right place and not in the bed. So, and another small things which you can do is, the child should void before retiring to bed. So say the child sleeps at 10 o'clock, so 9:30 or quarter to 10, take him to the toilet. So 2 hours before bedtime, or even longer, actually 4 to 6 hours, a small amount of liquid he can take, but try to stop having liquid, especially a whole glass of milk or tea or coffee or soft drinks. All these sort of things just before bedtime should be avoided, because as you know, many children have many parents actually have a habit of giving a whole glass of milk to the child just before sleeping. So it is one of the trigger for passing urine in the bed at night. So try to counsel the parents to avoid that extra intake of fluid. So that could be shifted to, say, the glass of milk at 4 5 p.m. so that when the child goes to bed, he doesn't have to get up to urinate in between. So maintain a urine diary, or we call it an enuresis chart, and with small rewards to be given for being dry. So what we discussed was that positive reinforcement. So when the child is not urinating in the bed, you have to positively reinforce that, give him a reward. Any small reward could be taking to the park or whatever the child likes. So some sort of a positive reward for being good, for being dry, and instead of scolding him for every time he passes in the bed, because all this kind of negative reinforcement makes the child more anxious, and he is more likely to pass urine in the bed. So if the child is dry, reward him. And older children, so that they learn that this is a problem, bedwetting, they can be asked to clean the laundry and the bed clothes when at night, when the parents are changing. Ask them to help in, they cannot change it in their own, of course, and ask them to help the parents in changing the bed clothes or the pajamas when they get wet. And another very important is an alarm clock technique. So alarm clock technique, there are two types of alarm clock technique. One is when your child sleeps, say the child sleeps at 9, 10 o'clock, you ask the parents to wake up the child at 2, 3 o'clock and take them for urination. So this is an alarm clock technique. And another is this alarm system, and which is an alarm bell, which is actually has a sensor in the underpant of the child. So whenever he passes urine, what happens is this alarm rings. So the parents or the child also gets up that there is a problem, right? So if there is anything like that, so the alarm bell rings, and he can know that there is mild wetting, so he can go and pass urine, right? So, and then the child can be taken for complete evacuation. So, most effective is your alarm therapy. Also, a few drugs which you might have heard of, like imipramine and desmopressin, they are used. But actually, again, I would say most important is your psychotherapy and your counseling of the parent as well as the child, right? Yeah, so pharmacotherapy consists of imipramine, desmopressin, and oxybutynin. But as we discussed, that most important is your psychotherapy. So all those points of psychotherapy are very important: positive reinforcement, alarm technique, and decrease your liquid intake. So these sort of patients, actually very commonly they come to the OPD also. So once you start seeing patients in OPD, you will have many of these patients, and all they need is actually a piece of counseling, some regulation of their liquid intake, and they do quite well. Most of them don't need all these pharmacotherapies, right? So next is your encoparesis. So encoparesis, as the name suggests, it is passage of stool after 4 years of age, and or equivalent. And as we say, it is one event or month or per month for at least 3 months. Okay. So here also, what is most important is your constipation. Yeah. So again, what is most important here again is your constipation. So 2/3 is what data mentions. 2/3 of it is due to constipation. But actually, if you sit in practice and start seeing patients in OPDs, 80 to 90% would be the ones who have constipation underlying. So if you treat the underlying constipation, most of these children do very well. So the usual history is that the child does pass stool, but it is the child doesn't know when he passes stool. So the parents usually come with the history of that the child has passed small amount of stool, or the underpants of the child are always stained with small amount of stool. So that they consider as encopresis. And usually what they think is that the child is having loose motions and he doesn't know that he's passing stool. But actually, when you take back the history, it would be like that the child hardly passes a proper stool. He just passes small amount of stool in the underpants, and mostly when he passes a proper stool after 4 or 5 days, it's usually very hard. It's usually with lot of straining. There's a lot of crying in the child. He has retentive maneuvers. Retentive maneuver means that, he withholds his stool. He doesn't like to go to the pot and sit there. So all this history will come out when you start asking about constipation. If you just ask the parents that does the child have constipation or does the child have hard stool, that's not enough, right? So that is very important. When you take history of constipation, it should not just be taking history of does the child have constipation or does the child pass hard stool, because what parents think constipation is passing stool in 4 to 5 days. Actually, that is not. So when you start taking history of whether the child has constipation, so I'll suggest you don't ask does the child have constipation, ask the parents how's the stool. So then they will tell you how is the stool, does he pass daily, what is the frequency of stool, what is the consistency of stool, does the child feel pain in the abdomen, does the child feel pain in the perineal area, does the child cry after passing stool, or does the child hold his stool, or he arches his back. This is all holding maneuvers. So that sort of history you ask rather than just a plain and simple line, does the child have constipation, right? So primary is same, like enuresis, primary and secondary are same. Primary is he's never attained the control. Secondary is when he did attain control and again became incontinent. So primary is more associated with developmental delay and is associated with enuresis. And secondary is the one which is associated with similar psychological stress that we discussed in detail previously, and conduct disorders, right? So do ask history of chronic constipation. I mentioned that in quite a lot of detail. Look for a fecal retention. Look for fecolids in the abdomen, small pellet-like, lumps you can feel from above the abdomen. Always palpate the abdomen of the child and do a perineal examination, do a rectal examination, look at the spine, look at the abdomen. So all this examination you have to do a thorough history in all those points of stool and a proper examination, right? So that is common to actually all your developmental disorders, right? So next is your investigations. So if you feel that your history is not conclusive of your diagnosis, then you can do an inner sphincter by electromyography or an MRI spine. But as I said, most of it is your based on history. Again, therapy is your behavioral therapy, psychotherapy, parental education. So here what is important is toilet training of the child. That you train the child to regular timed uninterrupted toileting. Train the child to sit on the pot because children are used to diapers, right? So train him that after every meal or once or twice a day after having something, eating something, he has to sit on the stool for 5 to 10 minutes. Sit on the pot, I mean, right? So that would help because after having something to eat, what normally occurs is a gastrocolic reflex, which is quite active in children. So when you encourage the parents to take the child to pass motion after eating food, it will be taking advantage of the gastrocolic reflex, which is normally in place. So that way the child would be able to pass an easy stool. So very important is a stool diary or a stool chart and a toilet training. Another is your so record or a toilet diary as we call it. So here also there is reward or positive reinforcement, any reward. and emphasizing the consistency that daily it has to be done, right? And then in this, actually pharmacotherapy is a part of treatment of constipation, because constipation will not just go with your uh, psychotherapy. So here laxatives and a good diet. Mostly the diet is defective in these children. That is mostly they are having milk-based diet. There is hardly any fruits, vegetables, or there is hardly any fiber in the diet. So that has to be taken care, that there is an improvement in the diet, and also there is introduction of your laxatives. So that is when the proper management of your encopresis or holistic management would take place, when you would take care of the constipation with your laxatives, high fiber diet, plenty of fluids, physical activity, and toilet training. That is once or twice a day. The child has to, you have to actually train the child to sit on the pot. So toilet training occurs when the child is made to sit on the pot on his own. So that is called as toilet training, and that is what has to be built so that these problems of constipation and encopresis can be avoided, right? Okay. Yeah. So the next we come to is temper tantrums. So these are episodes of disruptive, undesirable behavior or emotional outbursts, and they are severe in nature and are usually disproportionate to the situation. So this also, like your breath holding spells, is actually a temperament problem or a temperament behavioral disorder, as we may call it. And it usually occurs between 18 months to 4 years in that same age group of terrible toddlers, that young 18 months, 2-year-old children when they are very temperamental. So that is in the toddler age or in the pre-school age group this occurs. This is also more common in boys. And here also there are some psychological factors like we previously discussed, inconsistent parenting. What comes here is poor limit setting. This we previously didn't discuss. So poor limit setting means that there is no, what do you call, limit. There is no end to the demands. So when you don't put an end or you don't put a bar as to when, after which the child cannot go more than that, or he has to understand the meaning of no, that he cannot keep demanding, or he cannot keep asking for unrealistic things or unrealistic, be it anything unrealistic. It could be an object, it could be a demand for a food, it could be a demand for, say, going out, or any setting which is out of the limit, which is unrealistic. So when there is no limit to those settings, that is when these temper tantrums become more and more actually apparent. So when there is inconsistent parenting, that there is no, the child has never heard no from the parents or the family, that he will get whatever he demands, and when there is a no to him, he cannot stand it. So that is when these temperamental issues occur. So or there is excessive punishment, so it can be both ways. Either you pampered the child too much that he has never heard a no, or you punish him too much, or there is a problem in the family. There is inconsistent parenting, that one parent or one family member, say, just keeps pampering the child and listens to every another damn thing that he says. So all these kind of contribute to temper tantrums. Also, there are certain psychiatric and neurodevelopmental disorders which can be underlying and be the cause for your temper tantrums, right? So yeah. So predecessors can be unfulfilled demands, frustration, attention seeking behavior, okay, fear of fatigue, an overstimulating environment, hunger, physical discomfort. So actually this is all a repetition. So I guess how temper tantrums occur, and how the child, if his demands are not met, what the usual temper tantrums that occur. So clinical picture, so you would be aware of all this shouting, screaming, crying, falling to the floor, actually anything you can think of, and they would be doing that just to either hear a yes from you, or say gather attention, or just it's a behavioral thing, so they may just be doing it without realizing what they're doing. So that is the thing which could be occurring in the form of shouting, screaming, crying, just lying on the ground, flailing extremities, throwing around their limbs like, flail, head banging, banging their head on the wall, kicking, throwing items, breath holding spells, which we previously discussed. So any sort of this sort of behavior is a temper tantrum, right? So um, they usually last for 1 to 3 minutes, and sometimes they can last several times a day. Okay, so mostly they usually last one time a day, and sometimes they can last more than 4 to 5 times a day, right? Yeah. So management in this, again, you take a thorough history, that what is the problem in the family, what is the family dynamics, who is the one who's taking care of the child, who are the family members in the child. So take all that history. Is there any psychological problem? Why is the child throwing a tantrum? Okay. And look for any neurocutaneous marker or a problem in the CNS examination. Look for dysmorphism. Look for any visual or hearing problem. Maybe the child has a visual hearing deficit. That is why he throws a tantrum. So look for all organic causes. So again, in all these developmental disorders, look for organic cause. And only when you don't find it, then you label it as a temper tantrum or a behavioral disorder. Don't label it straight away. Oh, this child has a temper tantrum, or this child has a breath holding spell. It's not that clear cut. You have to take history, that does it occur when the child gets angry? Does it occur in a healthy child otherwise? Or he's just upset. Maybe that's why he's throwing these temper tantrums, right? So psychotherapy again is the main stay of therapy, and should be, so in this therapy we have to modify the parental response also. It's not that we do the therapy of the child and modify his behavior. You have to do parental response is also very important, that how do they deal with the tantrum. Mostly parents come to you that what should they do in such a situation when the child throws a tantrum, or he's say lying on the ground crying, head banging. What should they do when the child is banging their head on the ground, or say on the wall? So what is suggested is cause of the temper tantrum to be addressed. So is it just that the child is hungry and frustrated or fatigued or overtired, he has not slept? Has it been the trigger? Ignore. So if it is something of that, address it. Say the child is hungry or the child is sleepy, so take him, give him food, or say he's very sleepy, he didn't sleep at night, so let him sleep. In case you don't find any cause underlying, and it's just because of over exaggerated response of the child, ignore the behavior. So when the child is throwing a fit of his temper tantrum, ignore it and time out. So time out is an important strategy, and it means that when time should be provided to the child actually. So whenever the child is throwing a temper tantrum, let him be alone. Don't go cuddle him, hold him, pick him up from the ground and give him whatever he needs. That will lead to a vicious cycle of repeated behavior again and again. Again and again, what will happen is he will demand something. If he will not get it, he will start crying, he will throw a temper tantrum, he may even throw a spell. Then you will cuddle him, give him. So again and again, that sort of behavior gets uh, you know it gets encouraged, so it becomes a vicious cycle. So to break that vicious cycle, you give the child timeout. So timeout means leave the child alone. So give him time. After 2 to 3 minutes of lying on the floor, of doing all these tantrums, he will get calm. he will realize that, my demands are unrealistic, and he will come back to normal. So give them simple choices. Say he demands something, say, he wants to say play in a rainy day in say mud, but you or say he wants to not wear say woolen in the cold. So give him simple choices. Say if you instead of going out in the rain, maybe you can play with something else. So give him simple choices which are a replacement to what he's demanding. So that way you can tame his behavior. And most important is your timeout. What not has to be done, you have to counsel the parents not to overly cuddle the child, not to listen to all his demands. Give him time alone, give him time out, and you know, give him that peace of mind to realize what he has done, and not encourage this behavior again and again, right? So another important one is your PICA. PICA is your ingestion of non-nutritive substances for at least 1 month. We all know what is PICA is, eating mud, eating chalk, and which is actually developmentally inappropriate and not a part of cultural practice. And usually beyond 2 years of age, children have PICA, and it's a disorder of feeding and eating, right? So 2 to 10% is the one in general population. Okay. And usually it is associated with some nutrient deficiency. Mostly it's iron deficiency, sometimes in micronutrient deficiency or renal diseases, vitamin D deficiency, C deficiency. So sometimes it can occur in micronutrient deficiency, most commonly seen with iron deficiency, right? Okay. So sometimes it is also seen with your developmental conditions like global developmental delay, intellectual disability, autistic spectrum disorders, all these types of developmental conditions will be discussed in your next session on your behavioral disorders. Psychological factors like parental neglect, parental separation, all the family disputes I was talking about, lack of communication between family, environmental deprivation, traumatic events such as abuse, social isolation, the child stays alone, the parents they are busy or they don't pay attention to the child. So all this sort of behave most of these behavioral disorders had their origin in actually the psychosocial factors and the environmental factors. So whenever you look for these environmental behavioral disorders, do look for these psychological factors. Okay? So there can also be complications because of this pica. So anemia itself can trigger factor, and because of eating mud, it can trigger anemia because of lead. It can also have because of parasitic infections, hookworm infections. They also lead to anemia. There can be metabolic problems like hyperkalemia, metabolic alkalosis, poisoning, lead poisoning if the soil is rich in lead, and paint and all, and parasitic infections, hookworm, ascaris, all these sort of infections. And secondary to these parasites, there can be a bowel obstruction, a perforation, dental injury because of eating mud and chalk can damage the teeth. So these sort of problems actually pica can also cause. So iron deficiency is actually a reason for your pica, and it can also lead to iron deficiency. So that is important. When a child presents with pica, do think of iron deficiency and supplement iron on follow-up, right? Yeah, so management, yeah, we have come to the management, do the history. I'll, go fast a bit because I have only 10 minutes. So CBC peripheral smear to look for iron deficiency, or if you think of lead poisoning, do these levels only if you think it is something abnormal. Otherwise, these list of investigations are actually not needed. Just do a good history and physical examination, and you think it's pica, it is because of nutritional deficiency. Just supplement iron and there is dramatic response, the pica goes away like very good. So just supplement iron, deworm the child, and he does very well, right? Yeah. So no specific therapy, usually remits spontaneously. Multidisciplinary approach, like, iron and treatment like deworm the child. So behavioral strategies, like you tell the child what is mud, what is food. So let him discriminate between what is edible, what is non-edible. So this sort of behavioral therapy and psychotherapy, along with iron therapy, multivitamins, deworming, actually have dramatic effect and very good response in children with pica. If there is an underlying disorder like a developmental disorder, you obviously have to treat that, right? Yeah. So next is your head banging. So head banging is it's actually a part of temper tantrum. So most of it we covered it. It is compulsive, repetitive, rhythmic movement of the head against a solid objects, and it usually starts in the age here. Again, it's important. Age is first year, ends by 4 years. More common in boys again, and this is very important. That hardly there is any damage to the head when the child is head banging, because many times parents have this concern that the child is head banging, he is going to have an injury, so what to do, he's going to have a brain damage. So counsel the parents that mostly this head banging is not going to cause any injury to the child. It is a part of his behavioral disorder, and with time and with good psychotherapy it can improve, right? So another is your thumb sucking. So it's one of the very common disorders. It occurs in 1 to 4 years of age. And actually, it's not much of concern because children, they stop sucking of the thumb or fingers without intervention. Only if it occurs beyond 4 years of age that actually we have to do anything. Most of it actually goes on with the age, so you ignore the symptoms. Rarely, if it persists longer, can it cause dental problems. Okay. And in especially younger children, actually advice would be not to do anything, because children do thumb sucking because it is part of their behavior to satisfy themselves. Say the child, if he gets distressed, or if he feels worried or say anxious, he is going to do thumb sucking. So it is a way of him being calm or being peaceful. So between 1 to 4 years of age, actually it should not be stopped too much, unless it is beyond 4 years of age and actually the child is it is causing problems to the dental issues. Unless that is an issue, it should not be really discouraged that you pull the thumb out of the mouth, because the child is trying to get calm by thumb sucking. So it's not something to be really worried about. So nail biting is another one disorder, which is an onychophagia. It occurs in your developmental disorders like attention deficit hyperactivity, global developmental delay, intellectual disability, or in psychiatric illnesses. So problem with nail biting, as it's quite clear, because nails, they attract a lot of dirt and infection. So there can be diarrheal illnesses because of repeated biting. There can be dental problems. Very important is nail bed infections because of repeated trauma with the tooth and with the saliva. There can be dental nail bed infections. There can be fungal infections of the nail. There can be staph in the nail. So all that is very important. So nail biting, yes, it has to be avoided, and intraoral appliances can be used, and do rule out your comorbidity in them. So I think that's the end of it. And if any questions we can discuss, or if you want me to repeat any slide or discuss anything again, so we can discuss that. Or if any of you wants to give a comment or something, like like if you have heard of some other disorder, or you want to discuss something, then you can just put in the chat box. So no questions? Or if any of you wants to give any comments as to uh, if any other developmental disorder or any questions you want to discuss. Okay, so there is some question. One second. Why does head banging not hurt the child? Yeah, so head banging is actually not something which is occurring with a lot of force. Okay, so it is a behavioral thing. Usually what hurts the head is when there will be lot of impact. So when the child is actually banging his head, it is not with lot of impact. It just appears to him as rhythmic movement of the head which is more prominent, but the impact is quite less. So that is why it doesn't hurt the child. This is more of the movement which is there. So can nocturnal enuresis be genetic? So actually it's not genetic, but if there is some genetic or developmental disorder which runs in the family, like say there's a syndrome which runs in the family, any autosomal dominant or X-linked syndrome, then yes, it can be. But and another thing, it's not genetic, but there can be family issues which are there, like say there is a disputed family, or say there are family issues, there are issues with parenting. So that can always be in the other child also. Say if one child had difficulty in being continent, or there is a problem in their toilet training, so not really genetic, but yes, it can happen in families because of environmental issues. Okay, so I think that's it. Thank you. Okay, that's the 1 second. The questions: does the child not have any voluntary control over the breath holding spells? No, voluntary control is not there in breath holding spells. So if you actually go deep in the physiology of all this, so breath holding spell, there is always a trigger. So it's not that the child is doing it on his own, it's actually the physiology that there is a trigger, and that trigger frustrates the child. He starts crying, and then all this happens. So it's not that the child is doing it on his own, that he's a nasty child, he's doing it on his own. It's not that. There is a trigger. The trigger irritates the child, and then he gets upset. So we have to try to avoid trigger and help the child deal with all those anger problems and temperament issues. So next is, how does I'm putting her colic. Yeah, so last thing is, does the music help in colic? So actually all this is experimental stuff. So anything which suits the child could probably help it. So you can, mother's touch, mother's feel, breast milk, all this kind of help the child. Let the child lie on prone, let the child flex his legs. So all that helps the child to release the gas and helps in the gastrocolic reflex. So nail biting is not normal post puberty. You should look for iron deficiency or other nutritional disorders or some behavioral disorders. So nail biting is actually also being part of anxiety, or so psychotherapy and all that also helps even in nail biting. I didn't discuss that in detail, but nail biting also psychotherapy would help, because either it's a nutritional deficiency, or it is uh, an anxiety which is manifested. So most of these behavioral manifestations are actually psychological stress, either in the child or the adolescent, which is manifesting in the form of these behavioral disorders. And rarely there are these developmental disorders or autism or behavioral problems. Mostly it is a normal variant. So that's it. I think that's the end of it. So thank you and have a good day. Okay, so I'll end the session. Okay.